Welcome to the FINE Lecture Series. On behalf of the Perinatology Research Branch of NICHD and the National Institutes of Health, my name is Lami Yo, and I am one of the developers of FINE. In this presentation, you are going to learn about some new, exciting, and advanced features of FINE, or 5D Heart, that have been developed recently. All of this is important because you can use these tools to bring high-quality prenatal screening and diagnosis of congenital heart disease to all pregnant women. There are a lot of new features, so this will be reviewed in two separate presentations. This is part one, and here you will learn 5 ways to simplify the FINE method further. Everything that we will review here can be found in this 2020 scientific publication by our team. If you want to read this paper, please go to the main page of our YouTube channel, then click on this website link to the Perinatology Research Branch of NICHD and the National Institutes of Health. On that page, you can access all of our freely available scientific publications on the FINE method. Also, we encourage you to subscribe to our YouTube channel to learn more about FINE, its features, and practical implementation in the clinical setting. More educational presentations will be forthcoming. Now, before we discuss part one of the new and advanced features of FINE, let's briefly review the FINE method. This is a novel sonographic method to examine the fetal heart. FINE automatically generates and displays 9 standard fetal cardiac views simultaneously by applying intelligent navigation technology to stick volumes of the fetal heart. STIC stands for Spatiotemporal Image Correlation and is reviewed in other lectures of this YouTube series. FINE simplifies the fetal cardiac examination, shortens examination time, thus improving clinical efficiency and workflow, and reduces operator dependency. FINE consists of all of the features shown here. You can find detailed information about each of them in other presentations of this series. Now, we will briefly review the steps of the FINE method. The first step in FINE is to acquire a stick volume dataset. 4D sonography with STIC, or spatiotemporal image correlation technology, allows acquisition of a fetal cardiac volume dataset and visualization of cardiac structures as a cine loop of a complete single cardiac cycle in motion. We recommend that this be acquired from the 4-chamber view and within the 2nd and 3rd trimesters. With the 4-chamber view as the acquisition plane and applying appropriate settings, the volumetric ultrasound probe should automatically sweep from the fetal upper mediastinum down to the stomach in a vertex presentation. A stick volume acquisition is shown here, starting at the upper mediastinum, going through the 4-chamber view, and finally reaching the fetal stomach. The second step is stick loop. Once a stick volume has been acquired, FINE automatically converts the volume into a 2-dimensional cine loop that scrolls in a continuous fashion. This is why it is known as stick loop. We developed this tool to aid the user in determining the appropriateness of stick volumes before applying the FINE method to such volumes. Using stick loop, the operator observes whether or not certain criteria are met. You can learn about stick loop in other presentations of this series. The third step is anatomic box. Using this tool, the user marks or clicks on 7 anatomical structures within the stick volume. And once marking is completed, this triggers intelligent navigation technology. Find shows the user the 7 cardiac structures that need to be marked and in what specific order, as you can see from these buttons. And they are the aorta at the level of the stomach, aorta at the level of the 4-chamber view, crux, right atrial wall, pulmonary valve, superior vena cava, and finally the transverse aortic arch. This video shows the marking procedure. First, the aorta at the level of the stomach is marked. Next, the aorta at the 4-chamber view, the crux, the right atrial wall, the pulmonary valve, superior vena cava, and last, the transverse aortic arch. After the marking process has been completed, the last step is that FIND will automatically generate and display 9 fetal cardiac views simultaneously, and this takes several seconds. Here are the 9 fetal cardiac views in motion, displayed together in a single template for a normal fetal heart. Note that FIND also provides automatic labeling of each cardiac view, left and right sides of the fetus, cranial and caudal ends, and fetal anatomy. In summary, FIND involves the following steps. Acquire a stick volume. The volume is converted to stick loop, which is a 2-dimensional cine loop. Mark anatomical structures of the fetal heart using anatomic box. And finally, 9 fetal cardiac views are automatically generated. Now we will show FIND apply to a fetus with a normal heart. First, the aorta at the stomach is marked. Next, the aorta at the 4-chamber view, the crux, right atrial wall, the pulmonary valve, superior vena cava, and the transverse aortic arch. After this last mark, the 9 cardiac views are demonstrated with automatic labeling. For the purposes of this presentation, we have enlarged each of the cardiac diagnostic planes to show them to the user. This is the 3 vessels and trachea view, the 4-chamber view, 5-chamber view, left ventricular outflow tract, short axis view of the great vessels or right ventricular outflow tract, abdomen view, ductal arch, aortic arch, and finally the vena cava. Now, we will review the new and advanced features of FIND, Part 1. The features can be broadly classified into 3 goals: simplify the FIND method, perform quantitative fetal cardiac measurements, and improve the success of obtaining fetal cardiac views. In this presentation, we will review 5 ways to simplify the FIND method. In the next presentation, which is Part 2, we will review the other 2 goals. There are 5 new features to simplify the FIND method, and they are autofetal positioning or fine align, skip points, predictive or intelligent cursor placement, static mode volume, and breech sweep. First, we will discuss autofetal positioning or fine align. What does autofetal positioning or fine align do? Autofetal positioning affects the stick volume dataset itself and occurs during the marking process. It will automatically reorient and standardize the stick volume so the fetal spine is consistently placed at the 6 o'clock position. Autofetal positioning will also realign the stick volume to correct a fetal drifting spine. When is autofetal positioning activated? Autofetal positioning is activated in two situations. First, when the fetal spine is located outside the 5 to 7 o'clock range, leading to a spine location alert. The second situation is when there is a fetal drifting spine, leading to the possible drifting spine alert. A drifting spine is when the fetal spine location migrates on the monitor screen during the stick loop scroll. A horizontal drifting spine is when spinal ossification centers move in a lateral direction. Both situations will lead to difficulty in marking anatomical structures for fine. For example, here the fetal spine is at 6 o'clock, and for a vertex presentation, the superior vena cava in orange is located to the right of the image. However, for the second fetus, the spine is at 3 o'clock instead, and the identical superior vena cava is now in a different location, which may lead to difficulty in marking the superior vena cava. How does autofetal positioning simplify the fine method? Fetal anatomical structures for marking will be consistently displayed in the same manner each time. In other words, the spine is moved to 6 o'clock, thus more easily recognized by the cynologist, and or brought into the plane of sight. The drifting spine is corrected. Therefore, for any given fetus, each structure should always be in the same location on the screen. Here is an example of how autofetal positioning works. This fetal spine is originally between 7 and 8 o'clock. After the crux has been marked, a spine location alert for 7 to 8 o'clock will therefore automatically appear. Next, a stick volume reorientation message appears on the screen, asking whether volume reorientation to a spine at 6 o'clock should occur. If the user clicks yes, this will now happen, and the user will be asked by the system to mark the crux again. The marking process will continue as usual, but now the spine is at 6 o'clock. Because the spine is now at 6 o'clock, none of the 3 marking alerts will appear. But what happens if the user clicks no? The marking process will continue as usual, and the 3 marking alerts will appear in sequence. To learn about these alerts, please watch the Intelligent and Marking Alerts presentation in this YouTube series. This video demonstrates autofetal positioning live. The aorta at the stomach is marked. Next, the aorta at the 4-chamber view, and then the crux. The spine location alert appears along with the volume reorientation message. After clicking yes, the spine will now be moved to 6 o'clock, and the user is asked to mark the crux again. The marking process continues. Here the pulmonary valve is being marked, superior vena cava, transverse aortic arch, And now the 9 cardiac diagnostic planes are shown in a single template. A noteworthy point is that autofetal positioning will artificially place the spine at 6 o'clock for marking. But remember that at the time of stick volume acquisition, the fetus originally had a different spine location, in this case between 7 and 8 o'clock. Therefore, this feature will not correct issues such as acoustic shadowing or dropout from the ribs or spine, as seen here in the 9 cardiac diagnostic planes. The second and third new features to be discussed are skip points and predictive or intelligent cursor placement. Currently, the marking process is simplified for the user by showing a reference image. In this example, the pulmonary valve is supposed to be marked next. Therefore, a reference image of the pulmonary valve is shown to the user. This reference image teaches the user to mark the middle of the closed pulmonary valve. In addition, FIND automatically scrolls through the stick volume to the plane of the most likely location of the anatomical structure to be marked. Therefore, in this example, FIND will automatically present the plane to mark the pulmonary valve. Yet sometimes, for some users, there may be difficulty with the marking process. For example, if one is not familiar with fetal anatomy or there is poor visualization. This applies mainly to the right atrial wall, pulmonary valve, superior vena cava, and the transverse aortic arch. Therefore, a new technological feature of FIND is to skip one or more points and rely on predictive or intelligent cursor placement by intelligent navigation technology rather than relying on the user's judgment of where to mark. FIND does not place the cursor anywhere on the screen. Instead, FIND simplifies the marking process by automatically placing the cursor near or at the location to be marked. Predictive cursor placement occurs for the last 4 anatomical structures to be marked: the right atrial wall, pulmonary valve, superior vena cava, and transverse aortic arch. Normally, after the crux is marked, an angled green line will automatically appear that is locked at the crux. The long portion of the line should be placed by the user over the ventricular septum, while the short portion of the line is used to mark the right atrial wall. Now, with predictive cursor technology, the angled green line is automatically put into place by FIND, and the cursor should already be near or at the right atrial wall for marking. Similarly, FIND will automatically place the cursor near or at the pulmonary valve for marking, as well as near or at the superior vena cava for marking. And finally, FIND will automatically place the cursor near or at the transverse aortic arch for marking. This video shows the user marking the aorta at the stomach, 4-chamber view, and the crux using their own judgment. However, the remaining 4 anatomical structures have been marked by predictive cursor placement only. Note that although the cursor is not precisely on the structures, the resulting 9 cardiac views are still appropriate and informative. Moreover, the automatic labeling is still accurate in this example. The end result is improvement in workflow speed and decreased operator dependency. When should skip points and predictive cursor placement be used? First, when there is lack of familiarity with anatomy or uncertainty of where to mark structures. Second, suboptimal visualization or unclear structures. And marking the pulmonary valve when a static mode volume has been acquired. Essentially, relying on predictive cursor placement may yield better results than when one uses either incorrect judgment or guesses a structure's location, leading to marking the wrong areas within the stick volume. What if predictive cursor technology is used, but the resulting fetal cardiac views are not appropriate? There are three possible solutions besides choosing another stick volume. Apply VISA assistance, or virtual intelligent sonographer assistance, to the cardiac diagnostic plane. Mark all 7 anatomical structures based on the operator's judgment. Or perform Maestro planar navigation. All of this is reviewed in other lectures of this series. Is skip points and predictive cursor placement not appropriate for some cases? The answer is yes. Implementing such technology may not be appropriate for some types of congenital heart disease or if the overall image quality is poor. For cases of cardiac defects, predictive cursor placement may be incorrect due to abnormal anatomy. In this case, we recommend marking all 7 anatomical structures as usual. When the overall image quality is poor, as shown here on the right, although predictive cursor placement may be accurate, the resulting 9 cardiac views may still be uninterpretable and uninformative. The fourth new feature of FINE is static mode volume. As a brief reminder, obtaining stick volume datasets requires setting and acquisition time. When you set a longer acquisition time, the advantage is that there are a higher number of image frames obtained, and so there is a higher image resolution. However, disadvantages include a higher chance of introducing fetal breathing, motion artifacts into the stick volume, and also some mothers have difficulty holding their breath in this time frame. To address this, our goal was to establish an acquisition time that optimizes image resolution but minimizes artifacts. A static mode volume was therefore developed for FINE. This is a 3-dimensional static volume obtained via a very rapid acquisition time, 1 second, which is characterized by a high frame rate, leading to a data set with improved quality. FINE is applied to this static volume, and the resulting 9 cardiac views are static and without motion. This example shows a normal fetal heart in which FINE was applied to a static mode volume. Automatic labeling is also depicted. In this video clip, a static mode volume was acquired in which the fetal spine was originally located between 4 and 5 o'clock. Therefore, a spine location alert and volume reorientation message appears. After clicking Yes, the fetal spine is now placed at 6 o'clock. The marking process continues, and 9 normal cardiac diagnostic planes not in motion are depicted by FINE. It is noteworthy that just like stick volumes, stick loop criteria are still relevant for static mode volumes. In other words, static mode volumes are deemed appropriate before applying the FINE method if the stick loop criteria are met. A detailed review of each of these criteria can be found in other lectures in this series. What are the advantages of static mode volume combined with FINE? Even in the presence of fetal motion, hiccups, maternal breath hold issues, it may still be possible to acquire informative volumes. Second, motion and other artifacts should be reduced or avoided. and the overall time to perform the find method can be decreased. Although there is no acquisition time to set, the acquisition angle should still be determined prior to obtaining the static mode volume. The angle determines the acquisition depth. A smaller angle, such as 15 degrees, is equivalent to a shorter distance being covered during the static mode volume sweep. However, it is important to program the angle to a minimum value so that all fetal anatomic structures of interest are included in the sweep. For the find method, the upper fetal mediastinum through the stomach should be included within the static mode volume acquisition. The fetal upper mediastinum is defined as the plane in which the transverse aortic arch, superior vena cava, and trachea are visualized as shown here. The image on the right shows the fetal stomach in the abdomen. So what is the appropriate acquisition angle? This depends on the gestational age, which affects the fetal size. The answer is that the angle should always be adjusted depending on a smaller or larger fetal size. A good rule of thumb is to set the angle at least 5 degrees more than the gestational age. Therefore, if a fetus is 25 weeks of gestation, we set the acquisition angle to 30 degrees. However, the angle should not be too wide, since this can actually decrease image resolution. What is our approach to using static mode volumes? In general, we do not recommend obtaining static mode volumes when there is regular and frequent fetal breathing or very active fetuses, since this may result in artifacts within the volume dataset. Our approach when performing the find method is to initially obtain stick volumes. However, if this is not possible, or fetal movements and breathing preclude obtaining appropriate stick volumes, then static mode volumes may be acquired and fine applied to such volumes. There are a few noteworthy points about static mode volume in combination with fine. Neither the heart rate nor motion is considered using a static mode volume approach. Therefore, this cannot be used to assess events related to the cardiac cycle, as well as valvular and myocardial wall motion. Moreover, because the sweep captures cardiac structures randomly within the cardiac cycle, measurements of cardiac and outflow tract dimensions at a specific phase, such as end diastole, cannot be performed. Last, with static mode volume, fine will not incorporate cardiac phase recognition to facilitate marking of anatomical structures. Therefore, the atrioventricular and pulmonary valves may be open, therefore affecting marking of the crux and/or pulmonary valve using anatomic box. The last new feature to simplify the find method is known as breech sweep. Breech sweep technology is designed for breech presentations only. When there is a breech fetus, the motor array within the volumetric transducer switches directions so that the upper mediastinum is now seen at the start of the acquisition sweep. The goal is to minimize the probability of fetal breathing motion artifacts coinciding with the transducer sweep of cardiac structures. First, let's review the process of stick volume acquisition. If one sets an acquisition angle of 30 degrees, then from the acquisition plane, in this case the 4-chamber view, the stick volume dataset is created by a mechanical sweep of the transducer beam 15 degrees from this acquisition plane. The acquisition process then starts, coming back towards the acquisition plane, and then continuing for another 15 degrees to create a total volume of information of 30 degrees. Therefore, a total sweep of 30 degrees cranial and caudal to the 4-chamber view is obtained, in which the acquisition plane is located in the middle of the sweep box. So, for a 4-chamber view acquisition plane and vertex presentation, the upper mediastinum will be seen on the ultrasound monitor screen at the start of the sweep and the stomach at the end of the sweep. However, for a 4-chamber view acquisition plane but breech presentation, the opposite will occur. Instead, the stomach is seen at the start of the sweep and the upper mediastinum at the end of the sweep. Notice also that the cardiac apex and stomach are now seen on the right side of the screen. Please note that for both situations, there is equivalent anatomical information contained within the stick volume dataset. So why then was breech sweep created for the FINE method? For breech presentations, because the transducer sweep starts from the stomach and abdomen, there is a higher likelihood that fetal motion breathing artifacts will appear as the acquisition time passes, and this could coincide with the sweep occurring of the cardiac structures. Therefore, this could affect the cardiac views generated by FINE. To address this, breech sweep was introduced on the ultrasound system. If a fetus is breech and one plans to acquire a stick volume for analysis using FINE, first, the breech sweep button is pressed before activating the acquisition sweep. The motor array within the transducer will now switch directions so that the fetal upper mediastinum is now seen at the start of the sweep and the stomach at the end of the sweep. However, please note that although the sweep itself is reversed, the fetus is still in a true breech presentation. After the marking process is completed, FINE will generate 9 cardiac views as shown here. In summary, with a fetal breech presentation, the transducer sweep starts from the stomach and abdomen. However, when breech sweep is activated on the ultrasound machine for the same fetus, the motor array within the transducer will switch directions so that now the fetal upper mediastinum is seen at the start of the sweep and the stomach at the end of the sweep. Through this novel feature, there is a minimized chance that fetal breathing motion artifacts will coincide with the sweep of cardiac structures, which could adversely affect the cardiac images generated by FINE. Lastly, there are a few comments to be made. Despite the development of new and advanced features for the FINE method, the following axiom about 4D sonography with stick should still be followed. Specifically, the garbage in, garbage out principle used in computer science also applies. A stick volume dataset that is characterized by suboptimal or poor quality will produce undesired and uninformative output, since quality is essential for both post-processing and assessment. The new and advanced features of FINE described in this presentation cannot solve this issue or may not be applicable to some volumes. In conclusion, FINE automatically generates and displays 9 standard fetal cardiac views required to diagnose most cardiac abnormalities. FINE considerably simplifies fetal cardiac examination and reduces operator dependency. New and advanced features of FINE have recently been developed. We have reviewed 5 ways to simplify the FINE method further: auto fetal positioning or FINE align, skip points, predictive or intelligent cursor placement, static mode volume, and breech sweep. Please be sure to watch the next presentation, which will review more new and advanced features of FINE. These features now allow the user to perform quantitative fetal cardiac measurements and improve the success of obtaining fetal cardiac views. Thank you for your attention.